Hi guys, how are you? Uh, in this video, I'm going to do the gastrointestinal system. And as I mentioned to you in class, I think that gastrointestinal system, of all the systems that we've done, is probably the most high yield, meaning that when you go to, you know, to your core classes, this is what will truly matter. Med-surg, all of you will have to do it. And this is a sort of a preparation for that. Now, obviously, our class was only about 2 hours long, and this video will be like not even half an hour long. So not really too much that you can do. 2 hours of med-surg, that's not even funny to say that. That's way too short. Okay, so let's so you know what this is. This is simply a streamlined version of my lectures that will hopefully help you to remember the material, to think about it again. Okay, you do have your book and all other material, but hopefully this will help you one way or another. If not, I'm wasting my time. So I do hope it helps at least one of you. And if it does, I've done my job, okay? So, because some of you are visual learners and some of you are mainly auditory learners, hearing, but the best way to learn is actually to see and to hear, okay? To see and to hear and actually do. So doing would obviously mean you do questions, but we don't have too many questions, unfortunately. So let's do what we have. Okay, stick to what we have. All right, let me start by talking about dysphagia. And obviously, I'm going to be going over the material as I, have shared it with you in my checklists, right? So dysphagia, what is dysphagia? Dysphagia, macrophages, right? So phage, anything PHAG plus whatever means eating. Dys means something bad. So dysphagia is just difficulty eating, okay? So an easy term, all of you should know it just by doing neuroanatomy, your medical terminology, right? But what is the reason for dysphagia? Dysphagia can have a lot of reasons, right? Some of them we'll go over here, difficulty eating, why? And some of them you will learn in your core. Please do not mistake the term dysphagia, difficulty eating, with the term odynophagia, which means painful swallowing, painful eating, okay? Odynophagia versus dysphagia. All right, dysphagia is oftentimes associated with GERD. GERD, what is GERD? GERD is an acronym for gastroesophageal reflux disease. Reflux means what? It comes back. Gastro means what? Stomach. Esophagus means what? The food pipe. So it's a disease of the food pipe and the stomach. And why do patients get this disease? It's due to reflux. Reflux from where to where? Well, food goes from your mouth to esophagus to stomach, so it can't be called reflux. Reflux means coming, flow back, flux. Means what? Come back. So reflux is a flow back. Gastroesophageal reflux disease, okay? And how does the patient present? Patient presents with chest pain, heartburn. That's the term, heartburn, gastroesophageal reflux disease. Worst case would be for you when you're doing your med-surg, a young lady or a young guy. Well, let's say young lady, because it's mostly men who get heart attack, right? So let's say you have a young lady, youngish, let's say 35-year-old. She comes to your med-surg ward. That's where you do gastrointestinal surgeries. And she says, I think I'm going to have a heart attack. You can never take it not seriously. You do have to make sure that she doesn't have that heart attack, but she more likely has gastroesophageal reflux disease, okay, where food is coming back, irritating her esophagus, and she actually has heartburn, okay, not heart attack, heartburn, okay. All right, so a few terms: partial paralysis. Partial paralysis. Term for partial paralysis is paresis. P-A-R-E-S-I-S. Hemiparesis is a term that we did in the other video, right? Half paralysis, half partial paralysis. Well, there is a term, paresis, and you can stick it onto anything that moves. One gastrointestinal organ that moves is a stomach. Greek for stomach is gastro, so gastroparesis would be partial paralysis of the stomach. And that means that stomach cannot push that food out, remember, into the duodenum. And so there is a delayed gastric emptying, right? Delayed gastric emptying because it's not quite paralyzed, it's partially paralyzed. Partially paralyzed, it cannot push food down into the duodenum. And so patients have a problem with gastric emptying, but that too can cause gastroesophageal reflux disease. Why? Food, kind of collects in the stomach, more food collects in the stomach, and even more food collects in the stomach. Well, you remember it's a partial paralysis, so it can't really go down, right? So it goes back. Reflux, gastroesophageal reflux disease, flow back, okay? All right, so some more terms that you have to master would be hernia. Hernia is a bowel exit. When we talk about gastrointestinal hernias, right? It's when the bowel exits through a wall opening. So that opening is actually already there, okay? So some kind of a hole. And let's say an intestine runs parallel to that hole. Here's a hole, here's the intestine, right? So what if this intestine somehow squeezes through this previously present hole? Well, bad things can happen. And this process of squeezing through that previously available opening, hole, is called a hernia. And okay, do not confuse hernias with wall outpouchings. Wall outpouchings. Okay, so if there is a wall in an intestine, an intestinal pipe, essentially, sometimes you might have like a finger sticking out, right? I showed you in the class an example of a glove, right? Like a gloved finger may be sticking out of it. That's not a hernia. That's a diverticulus. Okay, single, diverticuli, plural. So bowel outpouchings are called diverticuli. Where are they most common? Diverticuli are most common here in the left lower quadrant. Left lower quadrant, okay? So do not confuse them with hernias. It's very easy to confuse diverticulitis, the pain in the lower left quadrant, with appendicitis, which is an inflammatory disease in the right lower quadrant. Okay, right lower quadrant. So the pain starts somewhere near in the umbilical area, okay, the umbilicus, and gradually localizes toward the right lower quadrant. And I explained to you in class why it so happens, right? So the pain is seen in the right lower quadrant in appendicitis, and left lower quadrant in diverticulitis. Okay, now, so let's say the patient does not have diverticulitis. The patient really has a bowel exit through the wall opening. We call it a hernia. Obviously, you can also have hernias in the brain, hernias anywhere else where there is a hole through which a part of an organ can prolapse. In the brain, for example, you know that you have openings where the nerves go through, where the spinal cord goes through. That's a pre-made opening. If the brain squeezes through that pre-made, previously available opening, we call it hernia as well, okay? So there are two kinds of hernias that you need to know. And they're really easy to remember. How do you remember them? Well, once again, let's go back to your intestine that runs parallel to this previously available hole. Previously available hole, intestine. What did we say? It has prolapsed. It has gone through that hole. And now it's sticking out here. You see this? Looking through if there's a better way to show it. Let me grab a cord. Okay. Okay, here's your hole. Okay, this is obviously a wall, right? But there is a hole in the wall. This is a pipe that runs through. Let's call, let that pipe be intestine. Okay, what did we say? It prolapses through here. Okay, this hole. Now, obviously, these holes have some kind of push on the inside, right? Normally. So now look at this. Look at this. This is the intestine. It has prolapsed through here, and the wall, and now it's sticking out of this ring, the hole, on the other side. Okay. Let's say you can reduce the amount of the hernia that's sticking out. You just push it back. You reduce the amount, right? You kind of like take it and push it to its original position. Take it and push it to its original position. Hey, go back. And now that intestine is running again parallel to this hole. This is called what you just did is called repositioning, positioning back to the previous position, taking an organ and putting it back to its original position. And how do you remember that? A reducible hernia starts with a RE, reducible. You have reduced the amount of tissue sticking out in the wrong place. You've reduced it, okay? And a reducible hernia can be repositioned to its original, 3 R's, original position, okay? That's a reducible one, okay? You had something sticking in here, you push it back. Now, what if you cannot reduce it? Well, what's the opposite of reducing? Reducing. Irreducible is the opposite of reducing. So you remember, there is a reducible hernia which you can push back, reposition to the original position, and there is an irreducible hernia. Irreducible starts with an I. And what happens in irreducible hernia? Oh, you can't push this intestine back to make it like free again. Did you say you can't make it free? You mean to say that the hernia is in jail, like incarcerated? That's exactly how you remember it. Irreducible hernia, another name is incarcerated. Incarcerated, okay. Now what's the problem with these incarcerated hernia? Watch this. What happens if I tie this cord around the finger? Well, blood won't be flowing there, okay. Tissue is going to die, and the bowel will die eventually. We call this strangulation. It's a term, it's a medical term, like exactly like that. Strangulation. Ischemia is the name. So strangulation, obviously no blood flows there. There's going to be ischemia. You know that, you know, strangulation, ischemia, and death of the tissue, necrosis. What happens if the bowel dies? I already told you in class, a gram of feces has over 1 billion, with a B, bacteria, okay? Just 1 gram of feces. What if it's like, you know, a part of the intestine? So it's quite a few grams. So can you imagine what will happen if this intestinal pipe, whether it's a colon full of bacteria or maybe something else with less bacteria, nevertheless dies? Well, what happens is that we have a tsunami of bacteria going into where they should never be, entering blood and causing death of the patient, 100% guaranteed. I mean, like if there is a severe if there is a large amount of bowel dying, there is absolutely, unless you act very, very, very quickly, even then you need luck. Okay, patient will probably die. All right, so bowel exit through the wall that is previously open. Okay, a wall opening is called a hernia. It can be reducible. You reduce it to the original position. You kind of reposition it to the original position, or it's irreducible. It's the opposite of that. So you cannot bring it back to free it. So you can't free it. All right, fine. Well, you've strangulated it in jail, incarceration. Irreducible hernia is incarcerated, can get strangulated, therefore ischemic, no blood flow there, and necrotic, tissue death at a cellular level. Okay? Do not confuse those hernias with diverticula. Please do not. All right. So a few terms that I noticed a few of you are not very comfortable with. Let's tear them apart, make them really easy. Passage of fresh blood with stool. So one goes to the bathroom and the stool is red in color. It's called bloody stool in English. Well, Greeks didn't speak English, and so they said bloody, hemato, heme, something with heme, and feces. Okay, and they didn't say feces or any other nicer words. They said chesia. Okay, so hematochesia is just blood in stool, period. Red stool, hematochesia. Okay, so the opposite of that, and we'll do this in your other video, is called hematuria. That's blood, heme, in urine. Hematuria, hematochesia versus hematuria. Okay, don't confuse the two terms. All right, what students confuse hematochesia with the most is the term called melena. And I kid you not, I actually knew a wife of one of my classmates, wife or girlfriend, I don't remember. I think he was already married. He was a little bit older than us. So her name was Melena, M-E-L-E-N-A. Okay, M-E-L-E-N-A. And what does melena mean? All of you have seen the road construction. You know that tarry consistency that they used for topping the road to make it very smooth? That's the tarry stool coloration that we're talking about. So if a patient does not have hematochesia, hematochesia means red stool, but passes black tarry stools, that's called melena. Why is that so? Well, you see We used to think it's just the acid, like literally when I was in med school, we used to think it's just acid acting on blood. But now we realize it's not just that. It's acid, it's the intestinal and stomach enzymes, and even bacteria acting on blood. Okay, so let's say someone has a gastric bleeding, gastric or esophageal bleeding. Esophageal bleeding would go down to the stomach, same thing. Mouth bleeding, same thing. Anything above the stomach, okay, above the duodenum. Okay, now listen, if those amounts are small enough that they can get bathed in acid, bathed in enzymes, and have sufficient time to be exposed to bacteria, we're going to have black tarry stools. Okay, and that's called melena. Melena, stomach or higher, small amounts. So if someone has like a gastric bleeding, like, I don't know, from, huge amounts, more than this cup, no chance to see any melena. You might have a little bit, it's going to get like washed out because blood will be very red in color. Too much, right? Too much. But if someone has sufficient, smaller amounts of blood, and the stool will be black, tarry in color, that's called melena. Now, what can cause that kind of a gastric bleeding? Back in the day, before medications that suppress acid came on the market, the PPIs, the proton pump inhibitors, you know them as omeprazole, right? So before those medications came on the market, Helicobacter pylori, helix like DNA, helix, bacter, Helicobacter, it's the name. It's just usually abbreviated as H. pylori. What does pylorus mean? It's the part of the stomach, just before the opening into the duodenum, the gatekeeper, pylorus, okay? So H. pylori, Helicobacter pylori, what it does is that it likes to live there in normal patients, in normal humans as well that are not affected with this disease, okay? But what it does in a good chunk of the population is that it can cause peptic ulcer. Peptic ulcers usually indicate stomach or duodenum, no specific area that you can think about. Okay, so you have to find out, is this stomach or is this duodenum? Okay, duodenal ulcer versus stomach ulcer. So Helicobacter, even esophagus is sometimes, but don't think about it, okay? So Helicobacter pylori, H. pylori, is the most common cause of peptic ulcers, okay? How does it do it? Kind of lives there, yeah, and we'll do what ulcer, the meaning of ulcer is coming up in ulcerative colitis, right? It's the damage to the mucosa. This is your mucosa, you can see it, right? And submucosa and even muscularis. So not just the superficial damage, right? So that's where the lower level is where the nerves are. So it's going to be painful. The lower levels are where your blood vessels are. So you're going to bleed. So every ulcer has a potential to bleed. Okay, so Helicobacter pylori drills holes in the mucosa of the stomach. Okay, and if it hits the wrong area where there is a blood vessel, like a fountain, that blood vessel blows up like a fountain. Okay, and you're going to have a major bleeding, which was back in the days before these medications came out that suppress acid. Gastric ulcers were the bane of surgeons' existence. Okay, they hated them because a patient went downhill very quickly. You had to react like so. Okay, but nowadays it's not. There are other things they're focusing on because this has been dealt with sufficiently. But do not overuse these medications. Do not overuse any medication, right? All right. So once again, remember the meaning of ulcer. We're going to do it again in a few. Okay, ulcer should never be confused with an erosion. Erosion is just a superficial layer. Mucosa, just mucosa is erosion. Erode, just a little bit erosion. Ulceration is mucosa plus submucosa and even maybe muscularis, the third layer, right? There are four layers, as you know from your anatomy. All right, so so if a patient has a lot of bleeding, okay, a lot of bleeding, one way to within the blood vessel. Let me walk it back again. If a patient has a bleeding in the blood vessel, you remember from our lecture about the blood diseases, right? Patient might have jaundice. Patient might have jaundice. Those the blood, heme in the blood, is taken to the kidney, is taken to the liver, and is first taken to the liver, and it's processed there into a thing called bilirubin. Okay, and basically that's the pigment in bile. Okay, so if the blood vessel is having a problem in the sense that the red blood cells are being killed, burst nonstop, autoimmune diseases of various kinds, etc., your bilirubin will be very dark. Okay, and the stones that will form will be black in color. Okay, and I showed it in class, just remember. And if it's cholesterol stones I showed you, they're going to be more like greenish, more fatty. Okay, all right, so bilirubin is kind of a dark colored pigment that's made in the liver when the red blood cell hemoglobin is released, and bilirubin is released in bile. Okay, so just a reminder that abnormal yellowing of the skin, and yellowing of skin is not, could be pretty much anything. It might be someone who is who has a tan. Okay, but yellowing of the sclerae, every single person should have white sclerae. Okay, if sclerae are yellow, this is a very strong indication of too much bilirubin in skin, and hyperbilirubinemia, too much bilirubin in skin, and this is called jaundice. Okay, too much bilirubin in skin, hyperbilirubinemia, and we call it jaundice. Okay, so just remember that cholelithiasis are stones. Lithos is a Greek for stone. Anything with chole is bile. So chole, stone, bile stones. Cholelithiasis, bile stones. Chole means bile. Lithos is a stone. Cholelithiasis is a term for gallstones. Another name, bile stone, cholelithiasis, gallstone, bile and gall, same thing. Gallstones are hardened deposits of bile that are in the stone, that are in the gallbladder. Okay, and why did I talk about this here? I want you to remember that, let's make a connection here, okay, that Helicobacter pylori causes ulceration in the stomach. Anything above the stomach, if it bleeds, it's black in color, and we call it melena, not hematochezia, which is red in color, right? So what if the blood vessel has a problem and the red blood cells are shot down? All that hemoglobin is going to go into bile. You're going to have black, tarry looking bile stones. not like cholesterol, the greenish looking. So now make that connection, just the color connection. Think back to my lecture, okay? So bilirubin is that dark colored pigment in the liver due to red blood cell loss, okay? Red blood cells releasing their hemoglobin that is normally excreted in bile, okay? Jaundice is what happens next. Jaundice is oftentimes due to cholelithiasis, okay? Because those stones essentially prevent passage of bile through the ducts into the esophagus, into the duodenum, and therefore there is a backward flow, reflux, into the liver, and then everything that is damaged in blood cannot basically be processed in the liver. All that bilirubin shows up on skin and sclerae jaundice. Okay, so remember that gallbladder and the pancreas share their exit to the liver, gallbladder, and pancreas live in the same corner of the body, right upper quadrant, right? And so if that gallstone were to block the main exit right next to the duodenum, that's called, you might hear about it, it's called ampulla of Bartter. Later on, never mind for now. What happens is that the road from liver to the duodenum is blocked. The road from the gallbladder to the duodenum is blocked, but what else is blocked? And I told you what else is blocked. That's the pancreas. So, so if pancreas cannot empty its juices into the duodenum, what happens? What's the function of pancreas? Digest fat, right? Well, it cannot digest fat now. Who is it going to digest? Itself, because it's got a lot of fat. That's correct. That's what happens. Okay. Pancreatitis. Pancreatitis, acute inflammation of pancreas. Pancreatitis. How is your patient going to present with pancreatitis? It's a very, very, very severe situation. First of all, extreme pain oftentimes. Okay. So severe epigastric. What's epigastric? Right here. Okay. Epigastric, above gastric. Well, we kind of define that area as epigastric. Okay. So what else will the patient have? Nausea, vomiting. Well, are you going to be hungry or what? If you can't process food? No, you're not. You're going to be like, don't give me any more food. So nausea and vomiting, quite the opposite. You're going to be you're going to have a reflux of that food, right? It's going to come back. So that's your vomiting. Nausea, vomiting, and severe epigastric pain. But what gives it away? What gives it away is that pain, the pancreas pain, pancreatitis pain, is not felt here, epigastric only. It's an epigastric pain that radiates to the back, okay? To the back, and that's your giveaway for pancreatitis. And I'll tell you why it radiates to the back, because pancreas is behind the peritoneum. And I hope you remember, I was showing you that peritoneum is like a bag holding all those intestinal organs, right? The double membrane that holds the intestinal pipes, essentially, attached to the vertebral body, right? I showed you with a paper. So pancreas is behind it. Let's think about it. It's behind the peritoneum, so it's retroperitoneal. Pancreas is behind, and that's why pancreas is behind the peritoneum. That's why the pain radiates to the back. There is epigastric pain because part of it is actually peritoneal, but a big chunk of it is retroperitoneal. So the pain radiates toward the back, okay? Just like the blood vessels. Aorta is behind the peritoneum. So if the aorta were to burst, patients would have retroperitoneal pain. They would say the back is hurting. not the tummy, okay, basically, all right? And this pain might get worse if you're lying down. I mean, seriously, if your right arm is hurting, and I tell you, your left arm is busy doing something else, and if I tell you, can you please give me a hand and hold this cup in your right hand, are you going to say, oh yeah, it's feeling much better now? Probably not, right? Just think like that. Okay. All right. There is a term that you need to know. It's called hemorrhoids. Hemorrhoids are often confused with varicose veins. And I already went over this in your blood vessels class, right? But I want to strengthen it again. Varicose veins are just dilated veins wherever they are. Can they be in the legs? Absolutely. Around the ankles, right? That's very common, especially as patients age, as humans age. They don't have to be pathologic. They do not, other than, other than optical imperfection, and some pay a lot of attention to that, and obviously it's their prerogative, right? They do not have any clinical abnormalities in the ankles, okay? But you can also have varicose veins in many other parts of the bodies. And sometimes they are very dangerous because they are dilated and may bleed, okay? So varicose veins in the perianal region, right? Around the anus, perianal, may be dilated and may bleed too. Do not confuse them with hemorrhoidal bleed. That's not the same thing. A hemorrhoid is that whole plexus prolapse. Basically, this is the anus. Hemorrhoids is a tissue going, depending on how severe hemorrhoids are, they may actually go through. Varicose veins are in place. They're just blood vessels that are dilated, stay around the anus and just bleed. Okay, so two different things, varicose veins versus hemorrhoids. And varicose veins are often due to alcoholism. Okay, why? Alcoholism causes cirrhosis. And cirrhosis, we had a presentation, cirrhosis. What does cirrhosis do? Well, in cirrhosis, patients develop fibrosis of the liver, the scarring of the liver. What happens in scarring? There's a permanent structural damage and the liver does not work anymore, right? So if the liver does not work anymore, can liver function? Not so well. Well, if the liver does not function, then what about all the blood that goes to the liver? Not so well. It doesn't flow there anymore. Oh, you mean like it's just like gastroparesis, the food would come back. It's like blood paresis. Exactly. Blood doesn't flow into the liver, so where does it flow? It flows back wherever it can. One of those areas is, for example, esophagus. So esophagus develops varicose veins. Okay, do not confuse with hemorrhoids. Anal area develops varicose veins too. Do not confuse with hemorrhoids. Here, you don't have hemorrhoids in the esophagus, right? So just remember that, okay? And if liver doesn't work very well, there is one more problem. There is a potential for too much fluid being built up in the abdomen between the two peritoneal layers, right? We call it ascites. Ascites is an abnormal fluid buildup in the abdomen. And the main cause of that is what? Well, we're talking about liver cirrhosis, all right? So what else can cause liver cirrhosis? Hepatitis. What is hepatitis? Itis, acute inflammation of hepar. What the heck is hepar? Liver. Hepatitis is acute inflammation of the liver. Easy to remember. So there are 5 viruses that you need to know. 5 viruses. They can be broken down into 2 groups. One group of viruses, and I've done all of this, goes through the through the bowels, through the mouth, comes out in the anus. Vowels go through the bowels. Hepatitis A and hepatitis E are the two viruses that go through the bowels, vowels. A, B, C, D, E. What is left? B, C, D. All right. So hepatitis B, C, and D are not vowels. They don't go through the bowels. How do they go? Hepatitis C, for example, is the most common cause of C, chronic. C, chronic. Chronic starts with a C. Hepatitis C is the most common cause of chronic hepatitis. What can it do? It can lead to cirrhosis and liver failure. Cirrhosis and liver failure, hepatitis C, okay? Because cirrhosis obviously leads to liver failure. All right, so we kind of talked about hernias, right? Hernia is when there is a prolapse. For example, I told you a bowel of different thickness that runs parallel to some opening. What if there is an extra pressure? It squeezes through. Reducible, push it back. Irreducible, suffocate, strangulate. Ischemia, necrosis, death. Okay, so there are other ways to cause these kinds of problems. And those other ways would be, how about we twist some of the bowel, like, exactly, because blood vessels go like so. Any twisting is similar to pressing on it. So if you twist, and that happens oftentimes in the sigmoid colon area, just before the rectum. Rectum empties into anus, right? So how does the large bowel look like? We have ascending, starts with the cecum. Cecum is a part of the ascending. If there is ascending, there is a descending. Ascending, and in between is the transverse. Ascending, transverse, descending, sigmoid, rectum, anus. So that sigmoid, and I showed you the picture, can rotate around a mesentery, the double-layered peritoneal membrane that has all of those blood vessels going to the intestine, right? So what if it twists around itself? Well, what happens is that we now call it volvulus. It revolves around that mesentery. Okay, so the volvulus may cause, where does it happen? Sigmoid, what is sigmoid? Large bowel? You bet. So sigmoid empties into the, I told you, ascending, transverse, descending, sigmoid, right? So sigmoid may cause a large bowel obstruction due to twisting of this part of the colon around its mesentery. And obviously, I mean, what can you do if it twists around itself? Is it going to untwist itself? Of course not, because it's not like hernia. You can't really see it. You can't really do much with your finger, right? So it requires a surgical intervention, okay? Surgical intervention. Remember, sigmoid problems would also be in the lower left quadrant, similar to diverticulitis. Lower left quadrant. So if you look at the patient, if I'm looking at you, it would be on the left side, my right, okay? And appendicitis is the right lower quadrant. Both need surgeries. All right. So the last thing that I wanted to review, because we talked about mucosa, we talked about submucosa, we talked about muscularis, and we talked about ulcerations, right? But so I don't want to go there because you already know it. Let's talk about Crohn's disease, which you should not confuse with ulcerative colitis, right? Because what is specific to Crohn's disease is that the damage is not only through mucosa or submucosa or muscularis, it's actually damage through the whole wall. Mucosa, submucosa, muscularis, and adventitia or serosa, right? So later on, because of this damage through the wall, right, what happens is that wherever this damage was, let's say you have a wall here, right? And imagine there is a penetration through the wall. Well, now that tissue is kind of dead. And what happens? Body has to fill it up. How would the body fill it up? Oh, it's going to place some scar tissue there, like fibrosis. So fibrosis then contracts. Okay, so you have a normal tissue surrounded by, let's say, a couple of damaged areas. Those damaged areas now, if this is the level of the healthy tissue, those damaged layers would be a little bit lower. So lower here, you have like a little island sticking out, island of healthy tissue. And I showed you the picture with the cobblestones, right? Surrounded by that moss. That's exactly how cobblestone mucosa looks like in Crohn's disease. C, Crohn's, cobblestone. C for Crohn's, C for cobblestone. Hepatitis C for chronic. C for chronic, hepatitis C. Now we're not talking about that. We're talking about Crohn's disease. We're talking about cobblestone mucosa. So later in course of Crohn's disease, mucosa has that cobblestone appearance, and that's because of the healthy normal tissue rising above the scar tissue. So it's just more obvious. You can see it. It's thicker, obviously, right? Because the other one has shrunk. And that tissue that is shrunk is, damaged by the fissures, we call them. Okay, the damage through the wall, or maybe ulcers. Okay, and so there is basically a scar here, and then there is a normal area. Okay, so there is a lesion, and so in between there is a normal area, and therefore we call these lesions skip lesions. Okay, they're not continuous, they're skip lesions. Okay, separated by healthy areas. So the colon has skip lesions. Do not confuse it with ulcerative colitis, where the lesion is like continuous. Okay. All right. This completes our gastroenterology review, and I'll see you soon.